The other thing about clinicians' discomfort with the treatment options is that I think both pharmacologic treatment and psychotherapy are thought to take a long time to start working. So sometimes in palliative care patients, people think, well, maybe it's just not worth it. That's not necessarily true either. There are certain medications that can be used even that work pretty much right away, like the stimulant medications. But even a week to a few weeks is not, that long, and you can see benefits from an SSRI. And with respect to psychotherapy, a lot of these patients don't have, a long-standing history of recurrent mood disorders. So it sometimes just takes, brief supportive interventions to really see a real benefit for helping these people. Another thing is that we all have discomfort with, I think, probing into these issues. I think death and dying are sort of, the fear of one's loss of oneself is sort of what underlies a lot of mood and anxiety symptoms over the course of one's life, even if one isn't directly facing their own mortality, as we see in palliative care. But that makes it all the more difficult, I think, for a lot of people to address these issues. But it's important to get comfortable with it over time. Certainly, clinicians may be sensitive to not being intrusive or upsetting the patients, and they may have their own discomfort with responding to psychological issues of the patient, so they may distance themselves to contain their own emotional distress, and they focus mainly on just physical symptoms. And then patients themselves can be sensitive to causing discomfort in clinicians. In one study, 11% of palliative care patients concealed feelings from others in their last week of life, and 35% were hesitant about self-disclosure about their feeling, emotions, or their mood. So it sometimes takes a little bit of gentle uncovering or exploration. Depression can happen, understandably, at all phases of, specifically of cancer treatment, from prior to diagnosis when they're undergoing investigation, and a patient might be very fearful in preparation for diagnosis, and then once they are diagnosed, they might experience almost like PTSD type symptoms, numbing, shock, along with sort of episodes of anxiety and sadness, and then over the course of the treatment, from side effects and pain, that can predispose eventually to taxing one's resources and emergent depressive symptoms. So in terms of some of the things that patients have to face that cause a mental strain on that might cause a mental strain on any one of us if we were diagnosed with cancer, is the threat and loss of physical integrity, possible decline in mental function or capacity, change in one's role in their family or in other aspects of their social life, increased dependence on the medical system and on others, and the ultimate prospect of death. The word cancer is sometimes still, synonymous with death. I mean, that's how it's perceived, so it's scary just to hear that word for people. So it's been found that, in general, some of the innate coping strategies that patients have can be protective against depression. You can screen for this and get a sense of this with patients that you're working with. If people are actively seeking social support, trying to solve problems, focusing on the positive, that's actually helpful and protective against depression. If you see people who are more passive and avoidant, who are withdrawing and ruminative, that's gonna, it's adaptive maybe in some areas, it's helpful to them in some areas, but when you're faced with a chronic illness that needs to be addressed and managed, these are difficult and problematic ways of coping that can lead to mood problems. Other concepts that we talk about in addition to major depression or some of the depressive disorders, are ideas generally of demoralization and distress. Again, a lot of the self-report measures that we use when we're studying depression include some symptoms that aren't really, the DSM-4 criteria for depression. They include anxiety symptoms. And it points to the idea that, these two things are often very comorbid and really there's this more amorphous concept of distress, and you have to sort of try to flesh out what is causing someone's distress when they're, when they're sort of experiencing chronic illness. They could have psychological and physical symptoms, and they all sort of interact in a complicated way. But as I was saying, you can have these symptoms being a normal part of your adjustment to having a life-threatening illness: anxiety, sadness, fatalism, grief. And demoralization is now a concept that sort of exists on the spectrum with disappointment and feeling. Really, it has to do ultimately with feeling like having a sense of loss of meaning. And the one way that it's distinguished from depression is one of the core features of depression is not considered to be present in demoralization, and that's anhedonia. Even if you become demoralized and you're trying to find some meaning in your life, you still might you might find that you're still engaging in the things that you normally like to be engaged in. Anhedonia is a difficult concept in itself to screen for with patients with cancer and chronic illness. And then, at a certain level, depressive disorders becomes more concerning, depressive symptoms for being disordered, specifically when they're interfering with functioning. They become severe, pervasive, sort of in more than one area of one's life, and prolonged. So I talked briefly about the idea that there are different ways in research, more than in the clinical setting, that depression is diagnosed. There's the idea that it's a criterion-based, like other medical diagnoses. And then there's the idea that depression exists more on a continuum, and some of these self-report measures have different thresholds where depression is diagnosed, after you get a certain number of symptoms, but it really points to the idea that these symptoms exist on a continuum.
So, could you just say something else about what you were saying before about anhedonia being more characteristic of depression than demoralized or because especially, like you said, how difficult it is to assess in people who are very ill, and is that because the symptoms themselves kind of overcome their ability to enjoy and engage in other ways, and it isn't so much an underlying pathology? Because I think about, like if we're going to refer, for example, when I say, someone seems sad, seems demoralized, seems upset in that way, and you can always say, going back to your first slide, well, of course they're upset, look at what they're dealing with. Right. Look at the symptoms that they're dealing with. Look at how limited their life is. So in that sense, it almost feels from a personal point of view, this makes sense. I wouldn't call this
well, but I don't think that, let me just say in the beginning, I don't think that should prevent you from referring or working with the patient, on any one of these issues, whether we call it depression or just sadness. I mean, even normal sadness is something that you want to offer, your ear to someone about, because I suppose if they end up withdrawing and people aren't offering their support, the people who are coping well will actively seek support. But by not being there to listen, you're making it harder for them to get support. So then that can lead to a risk of having more of a severe, prolonged, and pervasive depression. But anhedonia is one of the core features of the DSM-4 diagnosis of depression, and it is something that you see that remember there's like you have to have 5 of 9 criteria, but 2 of those you have to have, and the other 3 of 7 are optional, and that's depressed mood most of the time on most days, and anhedonia, which is a lack of interest or finding pleasure in the things you normally used to find pleasure in. So you can ask them that. I mean, after I talk to patients, I often sort of sometimes in this setting, figure out if they kind of meet criteria for depression, and that's one of the questions you ask them. What are the sort of things you used to like to do? Are you finding yourself not interested in doing those things? And if it's pervasive, I mean, even if they're not, even like talking to their family, things that don't take, that even a debilitated person can do, then you're really concerned. And that's something that you want to flesh out, because it's true. It's hard on the flip side to get that sense when people are debilitated. If they've lost energy and they just can't get out of the house, they still might say, well, I wish I could do some of the things that I used to do, but I can't. I look forward to the day when I will be able to return to do some of those things. Or I found, I used to like going to the movies. Now I'll watch a movie on TV. Even that, is not anhedonia. I mean, people who aren't watching TV or just sort of sleeping a lot of the day and aren't talking to their friends or their loved ones, that's more of a concern.